Again, if you've just joined, um, please introduce yourself in the chat. We'd love to see who is here and also for others to get a chance to know who else is on as well. We are still waiting on one of our panelists, so we'll give it another couple of minutes. In the meantime, I just wanted to welcome everyone. This is our monthly Wisdom Study Community Forum. We've been hosting these meetings for just over a year now. And really the goal of these meetings and these discussions are to have a dialogue around different topics around breast health and breast cancer, breast screening, to be able to share information that we collectively are gathering and are learning together to try and improve our approach to not only breast cancer screening, but breast cancer treatment as well. So I appreciate everyone joining today. We always ask at the end if you have suggestions for other topics that you'd like to hear. Again, we do this on a monthly basis, so are always looking to hear what other topics might be of interest to you. So please do let us know what your suggestions are, and we'll be sure to add those suggestions to our upcoming meetings. The next meeting is at the end of March. They're always the last Monday of every month. Barring a holiday, but the last Monday of every month from 4 to 5 p.m. Pacific time. And I see some familiar faces here, some members of our community leadership board, some of our collaborators from across the country, and just want to welcome everyone here today. And thanks so much for joining. And we'll get started in just a couple minutes. Okay, I see Dr. Horton arriving, so I will go ahead and launch. Again, thanks everyone for joining our February 2023 monthly community forum for the Wisdom Study. Just a quick format for today's session. We do want to hear from you. We would love to hear your questions, your comments, your concerns. So you can either add those questions to the chat in Zoom. You can also, there's a raise your hand feature you're welcome to use. Feel free to submit questions throughout the discussion. We want to try and make this as engaging and have a dialogue as much as possible, not just all presentations. So please add those questions in as we go through. When you're not speaking, we do ask that you mute yourself so that there isn't any background noise. We are recording these meetings. We share them on our website, on our YouTube channel, so that for those people who aren't able to join, they can watch it later. And for previous community forums that you may have missed, they're all on our YouTube channel, and we'll send everyone the link if you want to access some of the other topics that we've discussed. And then I think there should be a short survey that we'll send out after, and we'd love to hear your feedback, what you liked, what you didn't like. And again, if you have ideas for other topics that you'd like to see on these forums. All right, so the mission, as I mentioned, for all of us and for what we're all here for is really to try and move together towards equity and better outcomes in breast cancer for everyone. Really trying to understand how we can do a better job of not only screening and preventing breast cancer, but treating as well, and making sure that the voice of the community, of our patients, of our communities are part of our approach to providing both care and research. Those voices are most important so that we know the questions that we're asking and the topics that we're looking at are most meaningful to the community at large and to our individual patients. So just to start off and set the stage, breast cancer screening, breast cancer treatment is not perfect. That's why we're continuing to try and do research and try and improve what we know. We know that breast cancer is not one disease. We know that some forms of breast cancer can be very slow growing and may not impact your life expectancy. Other forms of breast cancer can be very aggressive, and where screening may not actually have too much of an impact on your outcomes. And so we're really trying to understand how we can screen and tailor screening to someone's risk of developing each type of breast cancer. We know that younger women are at risk for more aggressive cancers. And as we'll talk about today, there are certain communities for which that's even more true than others. We know that family history is only one piece of the puzzle. Oftentimes, we think of family history as being sort of the warning sign or the indicator that someone will get breast cancer, but we know that's not actually true. There are lots of other factors that go into who develops breast cancer and who doesn't. One thing that we've learned so far in the Wisdom study is that of the women that we've tested for genetic mutations, so those women in our personalized arm of the study, of those that had a genetic mutation, 60% did not have a first-degree family member who has had breast cancer in the past. So we know that just using family history is not the most comprehensive way that we can start looking at risk and to try and understand who may develop breast cancer in the future. We also know that breast cancer outcomes are worse for some communities. And again, we'll talk about that today in our topic around breast cancer in the Black community. Just a quick overview sampling of what topics we've talked about in the past. You can see we have talked about this topic in the past about breast cancer and outcomes in the Black and African American community. That was one of our very first community forums we did over a year ago. We've done a forum on breast cancer risk factors, including density, the importance of clinical trial participation, genetics and family history, breast cancer across the lifespan, including in young women and menopause. Last month, we did breast cancer and nutrition. And then this month, we'll talk about breast cancer in the Black and African American community. Again, all of these recordings are available, and we'd be happy to send the link out if you would like to listen to any of them and use those as resources as well. So as I mentioned, this month we're celebrating Black History Month, and in celebration of Black History Month, we wanted to recognize many of our collaborators, investigators, who are part of our mission to try and improve breast cancer screening and outcomes. You can see some photos here. We've featured a few people as part of our Wisdom study social media in the last few weeks. But all of these women are making a difference in trying to improve breast cancer screening and outcomes, particularly as Black or African American women in science and in medicine. So just want to thank everyone for your participation. I know I'm sure I've missed someone on this slide, but wanted to just give some faces to the community that we've formed, the scientific and research and clinical community that we've formed around the Wisdom study. So thank you to those who are on and for those who participate. And we are always looking for new members, new voices, and new collaborators as well. So would love if you're interested in continuing and engaging in a dialogue with us and participating in some of our stories, please do let us know. And also just to note as we head into March, which is actually Women's History Month, but just to thank all of our Wisdom participants and supporters for making history in this large research trial. We are trying to make an improvement in the way we screen, and research studies like this are the way to do that. So thank you to those who are participating. Thank you to those who are engaged and part of our conversation. Together we can make a difference, and together we can try and shift our approach so that we can improve the way we screen and detect for breast cancer. All right. So on that, our discussants for today, we have Dr. Sarah Horton, who is a medical oncologist at Howard University, also the executive director of Access and Diversity at Quantum Leap Healthcare Collaborative. Laura Esserman, who is the director of the UCSF Breast Care Center and also the lead for the Wisdom study and the I-SPY trials will also be on in about 15 minutes. She'll be joining us. And then myself, I'm Allison Piscolini. I'm the director of the Athena Breast Health Network and the Wisdom Study as well. So we're excited to have you on today. And again, please feel free to ask your questions throughout. I'll be monitoring the chat and we can go from there. So without further ado, Sarah, I will pass things to you.
Okay. Thank you, Allison. And I'm always, as usual, really glad to be here to talk about wisdom. As Allison said, I'm a medical oncologist for over 20 some years now. Academically, I was based at Howard University for the longest, where we did clinical trials with a population of primarily Black and Hispanic patients. So it's this topic is very important to the community that I worked a lot with, as well as to just the community as a whole, the importance of better screening than what we have now to improve the outcomes of patients. So I love the Wisdom trial, everything about it, the fact that it's easy for women to enroll, the fact that it's using personalized medicine to better target risk in women. And so today, what I'll do is just do a couple of slides on the background, just in general, specifically Black women and breast cancer, because as most of you have heard many times that when we talk about breast cancer in Black women, we talk about the worst outcomes that we have when, if diagnosed overall. Doesn't mean every Black woman who gets breast cancer is going to do worse, just means as a whole, for some reason, Black women do not live as long as other women when they have breast cancer. So we're trying to attack that from different ways: screen better, treat better, and Wisdom Study specifically is looking at that role of screening. So this slide just is a picture of what we call incidence and mortality. Incidence is how often the disease happens in a population. Mortality is how often people die from the disease. And so the first two columns are non-Hispanic white patients. We know there's a high incidence. These are the African-American patients. Also high, but not quite as high. And what the disparity is that even though there's a lower incidence in breast cancer, there's a higher mortality, 29% mortality compared to a 20.8% in white women. So it's higher in African-American women. And what you'll hear also is that if an African-American woman is diagnosed with breast cancer, she has a 41% chance of dying. So when we look at the other ethnicities, we have a little lower incidence, we have lower mortalities. We want to bring those numbers even down further with better screening. But focusing on Black women, we know that among women who are younger also, when we're looking at reasons why mortality is higher in Black women, we find that there's a higher number of younger women younger Black women who develop breast cancer, and younger women tend to have more aggressive breast cancers too. We think all of those things contribute to the increased mortality. So some additional numbers. I spoke a little bit about the number that Black women, when they're diagnosed with breast cancer, die at a 41% higher rate than white women. And that's the mortality rate, even though the incidence rate, how often it occurs, is about the same. And again, women who are diagnosed at less than 50, younger women, Black women, die twice the rate as white women in that group. So we know that in the makeup of the US, Black people make up about 12% of the population. But when you look at clinical trials, and this is something we talk about a lot, unfortunately, it's about 3% of all clinical trial participants are African American or Black. And those are trials that led to FDA approval of drugs for breast cancer between 2008 and 2018. So that's looking at all these great new drugs that have come out that we talk about: immunotherapy, targeted therapy, all of these drugs that are decreasing the effects of breast cancer and increasing survival. When you look at the patients who benefited first by being on those trials, those are the numbers when we talk about only 3% were African American, also the Hispanic population in the clinical trials is low, kind of single digits too, usually about 4 or 5%. And we want to increase those numbers so that we have the impact of these beneficial drugs sooner in all patients. So Black patients had the lowest, clinical trial rate across all the ethnic groups, and that's even for triple negative breast cancer. And you may or may not know that triple negative breast cancer has a much higher incidence in the African American community. It's also a more aggressive breast cancer. And so it's really important that we get good drugs that work well in this disease. Okay. Next slide, please. So why is participation in clinical trials important? I spoke a little bit about, being in a clinical trial is a way of early access to some of the best medications. Clinical trial participants, though, should represent the women who are going to be using that therapy. And so we know that, as the numbers increase in our population, and we know that every woman has a 1 in 8 chance of developing breast cancer, we think that the number of women should be equally represented on clinical trials as they are represented in the population. And the reason that's important is because we're at a level of science now where we can look at the genetics and the molecular makeup of the cancers. We know that a lot of the ways that the cancers work are based on the genes and how they may have mutations and may not. We know that varies in different people. That's why we call it personalized medicine, when we use medications that are targeted towards something specific that we may have found in that person's tumor. So why is that important for diversity? Well, as a group and as a whole of people, we know that some genetic changes occur more often in certain types of ethnicities. For instance, the BRCA gene was identified in Ashkenazi Jewish women. And that was huge. It was huge. Once that was identified, there was a drug that was made targeted toward it, and it saved lives. And we know to look for this, and we have measures to prevent breast cancer from happening in these women. So what we want to do now is look at other groups of people. And as we get the information about different groups, and specifically look at the genetics within that group, it can help us to determine whether there are some drugs that work better in that population than others. And the only way that we will determine whether there is an increased incidence of a certain mutation in a certain group is if that group is studied. And usually the way to get studied is on a clinical trial. And again, that's how the BRCA gene was identified. The group of patients decided, yes, we have a lot of breast cancer in our community. We want to figure out why. We will, agree to be studied on a trial, and the BRCA gene was identified. So we also know that there's an underrepresentation of older patients in clinical trials, and that's something that we need to work on. I think about this a lot. When I was a fellow years ago, I remember that in the NCCN guidelines, the guidelines that we use in terms of deciding how to treat patients, the standard, there was no guideline for treating women over 70. And so, it just wasn't necessarily recommended. It just said there's no evidence, because there wasn't a push to enroll women over 70 on clinical trials. So there was, no real data-backed evidence to say what a drug was going to do in that population. So there's been a push to, as we live longer, and we know that as we get older, we can tolerate drugs very similarly to younger people, to diversify our clinical trials with older patients, with more diverse patients. And then as we look again at some of the limitations we have on the patients that we study, we're trying to get more liberal in terms of the type of patients who can actually be on clinical trials. And as the last sentence says, reasons for limited participation are multidimensional. So when you're in a clinical trial, you do want to be safe. The mantra of the FDA is to find drugs that are safe and effective. So you want something that works, but you also want something that's not going to cause serious problems or more problems than you may already have. And so we do have to have some limitations on the patients we can enroll in studies, but I think we're getting better at choosing where our criteria is. Next slide, please.
Just real quick, one question that I know we get in the wisdom study, because we're not a study with people who have been diagnosed, it's for healthy women who haven't had a diagnosis of breast cancer in the past, and there's not a drug or something that's being tested. Can you speak to the benefits of participating in a large screening trial where maybe we're trying to find, different approaches or different ways to understand risk? It's a little bit different than saying understanding the effectiveness of a drug. There's so maybe some more information on that.
Okay, I'm sorry. I'm so used to talking about treatment trials, and
No,
again,
that's fine.
that's another reason I love the wisdom study. I kind of call it a gateway study because it's a wonderful way to be introduced to clinical research, because you get the benefit of finding out about you and your body and your risk and how you can potentially prevent disease in the future without having to take something, and along with not having to take a drug or undergo a procedure, you also don't have to go in anywhere, and show up for a bunch of appointments, because the wisdom study can be done on a mobile device or your computer and mailed in. And so for a prevention study, not only do you specifically for the wisdom study, you are able to find out information about not only your risk for breast cancer, but you get the genetic profiling, which I think is really unique and super important for women to know, along with the genetic counseling, which is also as important as the study. Having someone who is explaining it to you, telling you what it means, so that you can be informed about the results that you're getting from the study. And so there are few prevention studies out there, but for one of the really uniquely important things about wisdom study is that right now recommendations for mammography is the same for all women across the board. And we know that all women are not the same, and not all women develop breast cancer, have the same risk. And so there are some models, some old kind of outdated models that have been used to determine the risk for women. You've heard of the Gale model, where we're looking at things like your menstrual cycle and family history. And when family history was used, it was your first degree relatives only. And things like, if you've had children or not, and if you breastfed, all of those are still very important and are part of determining risk. But we also know now, especially with genetics, that there are some real factors that we have data that we can put numbers on that show that that can increase your risk of specifically breast cancer in this situation, a certain percentage. And I think knowing that information is power in terms of determining how and when you should be screened. And so we don't know the exact answer yet about how to use all this information. And that's what wisdom is for, is to take your genetic information, to take all the information that we usually get in terms of risk, to also look at breast density, which is right now not used to determine your risk and whether you should get screening more often. It's in the process of determining. We know that, I'll step back. We know that dense breasts increases your risk of breast cancer. We have not historically measured density of breasts, so we're not sure of the exact increase in risk and the women who would actually benefit from some type of change in their screening. But the wisdom study incorporates breast density. So that's another area that we'll be finding out more information about. And so you've got your genetic profiling, you've got your risk assessment that we've used, you've got breast density as well. And all of this is put within a clinical trial that will give you your own personal recommendations for when you start your mammograms and how often you should get them, more or less based on your scores. The other thing that I like about this study is that you have the option of accepting that recommendation and following it, or if you're not 100% comfortable, say you are a woman who your risk is less than the average woman and the recommendation is made for less screening, there is the option for an observation arm. So you still can be included in the clinical research. You can be followed, your data will be followed up on and included, but you don't necessarily have to either screen more or less if you don't want to follow the recommendation.
And
So go ahead.
there's a question in the chat too about having the opportunity to participate in a trial, particularly for women of African descent. The question is specific to the DigniCap trial or therapy, but maybe just in general access to clinical trials, and what are some of the barriers and what are some ways that we can try and overcome those barriers to ensure that people do have the opportunity to participate.
Well, the barriers to participating are varied, and it's a great question because we have to look at it from a lot of different directions. One is the neighborhoods where the people live, right? So if you receive your care in an area at a hospital or a community center that doesn't participate in clinical research, then right off the bat, you're at a disadvantage. You may never be offered a study. And if you're never offered it, unless you are really motivated to be in a clinical trial, you may never even consider a clinical trial. So one is to try to get clinical trials into the places where people receive their care. And there are some networks that are trying to develop community cancer center clinical trial networks, where smaller centers, which may not be able to support clinical research on their own, can be a part of a larger community of research. And that's happening amongst some of the county hospitals in certain states. The other thing is to make the study easier for the patient. Again, Wisdom is, to me, an example of that. This is what we call kind of a decentralized study, where you don't have to go into a place. You register online, and things are mailed to you that you mail back. And so anyone can do this study. I also like that Wisdom has hubs. And so this is a way to get over barriers too, where and when I say Wisdom as hubs, they'll have people who are at a certain site, be it an academic site, a university, or a research site, that can be boots on the ground if someone needs to help with something, maybe getting a report, and if you have a hub in an area that sees a lot of diverse patients, you can increase your access to patients who normally wouldn't have clinical trials. And something like this study with the Wisdom study, you don't even have to have a big clinical research program to be a hub. So thinking out of the box, getting the clinical trials into places where they're not usually done. People are thinking about the way they write clinical trials to make it easier for people to be a part of them. When we talk about decentralizing, making it so the patients don't have to come in multiple times. Maybe you can go to a neighborhood lab to get your blood drawn. Maybe a nurse can come out to you to get your blood drawn. So those are just a few of the ways that we're thinking about overcoming barriers to enrollment on clinical trials.
Thank you. There was also a clarification if the 3% participation rate for Black or African American women is for treatment trials, or if we have any stats on screening trials too. I know I have some numbers I'll show about the Wisdom study, but I don't know in general for other screening studies. That's something we may need to look up. I'm not sure if you know.
Yeah, no, because there are not a lot of screening studies, so I don't know. It'll be interesting and good to hear those numbers though for Wisdom, which is one of the largest screening trials we have.
Okay. And again, please feel free to put your questions in the chat. I think just a question for our attendees, have you ever participated in a trial? And what do you find motivating to participate? I think that's always a question that we're asking ourselves is, how can we make trial participation easy, but also have there be a benefit back to the participant? And in a screening trial, I think that's, where there's not a treatment being given, that's a question that we face all the time is giving someone back their risk assessment or their genetic information sort of enough? Or is there more of an incentive that people need to participate in trials? Or are there concerns that we need to make sure that we address? And I know that those concerns may be different across communities. And I don't know, Sarah, if you want to speak a little bit to perhaps some concerns that the Black and African American community may have that you've heard of, or just in general concerns about trial participation.
Yes, right. One of the things that we know now that used to be a reason that people thought that there wasn't participation is that specifically in the Black community, that Black patients didn't want to participate in research, that they felt it was experimental, and that, we felt that there was a mistrust. There's probably still some of that, but as across the board, and my personal experience has been, if asked to be in a clinical trial, then Black patient will participate just as often as any other patient. And that's also been shown in the Hispanic community as well. And so we're trying to debunk that myth so that from a provider standpoint, there's no hesitancy felt, in asking a patient to participate. Also, in the Black community, there is an importance on trusting the person who is giving you your care. And so if there is a study that is coming to either an academic center or a community center within a community of people of color, it's usually important to develop a relationship with the community. So outreach, getting to know what the community wants and feels is important, to make sure you have buy-in, that there's feedback to the community about the study and the results, to make sure up front that they know that, to have them involved as an, as a advisory group of some sort. So I think all of those things I've seen are beneficial in providing a good environment for clinical research. And I'll add one last comment that I hear more of these days is just about your genetic information. It's like, who has it and what are they doing with it? And, how can I be, sure that, no one's giving my information away? And so again, Wisdom does a great job of being really clear that this is your information and how it's handled, it's given to you. And I think it's an important question because there are different trials that may not be as, as transparent in terms of what's going on with data. So I think that's one of the newer concerns.
Great. All right. And then I know other questions that have come up in the past are around, there was actually an article that came out back in the end of 2021, beginning of 2022. This was one of our first community forums that we discussed this topic. And it was suggesting that because of the risk of breast cancer at younger ages, the more aggressive breast cancer at younger ages, that Black women as a whole should consider screening before the age of 40, just as a community, not individual risk assessment. And we had a big discussion about this on our community forum and just wanted to bring that back up to see. And it looks like Laura Esserman has joined us now too. What are some considerations we should think about with that sort of blanket statement that one group or another should start screening earlier or differently? What are the pros and the cons to that, or what are some other considerations?
Well, I think it's one of those interesting things that this came up as the whole thing that's wrong with screening today is that we try and do the same thing for everybody, but in fact, that's probably not the best solution. The interesting thing is that African American women get breast cancer less frequently, but they tend to have a higher mortality rate. So if they get it, it's often more aggressive or more serious. So the trick is, just like for everybody, what can we do to try and find the people at highest risk and do more for those, and maybe, take the people where we know we're at lowest risk and do less for them. And how can we also adjust that to what we know about genetics? So one of the solutions is to say, okay, well, mutations, that's low-hanging fruit. Finding the people who have an inherited predisposition to breast cancer, it's better to do the test than it is to ask about family history, because everybody doesn't know their family history. And we found that 60% of the people with mutations in wisdom didn't actually have the family history. So that looking for the gene, the error in the gene itself, is probably better. Again, that's not the majority of women, but it's still in a very important group of people who are at high risk. So that's maybe 1 or 2% of the population. And then there's the group of people who have, it depends upon your background, the inherited combinations of other genes that can predict risk, or combinations of other risk factors that might make a difference, where we could try and pick a group of people, 5 or 6% of the population, to screen more frequently. And that's the idea, right, behind this. And then the only way to find out is to, track people and follow, is that right? Did we get it right? That's the part of what we're trying to figure out with wisdom, is if we make these assignments, how do we do that? And, are we continuing to make progress? And, it's interesting that of the very high risk cancers in the I-SPY program that we run for high risk women, about 20% of women have an inherited predisposition. And that seems pretty high, but those aggressive cancers, there's a higher proportion that is in, of people who have genetic predisposition in these faster and more aggressive cancers. So I think it's certainly a good start. It's not the perfect answer, but I think it's a good place to start. What do people think about that?
Just to give a little insight to the wisdom study for the personalized arm. So that's the one with the genetic testing for people who choose. About 80% of people over the course of the study have chosen the personalized arm. Not everyone has completed the genetic testing in that arm, but the majority of people have. So I think that's a relatively good indicator that people are comfortable completing that and having it part of their risk assessment, though it is something that we're continuing to try and provide new sort of educational materials around, and really try and make sure it's clear, as Sarah said, what the information does and where it goes, which it stays with the study. It's yours. It's not shared to anyone else. So really trying to instill that trust in the data that we're capturing as part of the research study as well.
And as Dr. Esterman made the comment about the importance of knowing beyond the BRCA genes. I mean, there are a lot of genes that we're finding out that impact risk for breast cancer. But we really won't know the extent unless they're studied and the patients followed, and we see if those actual mutations that are found result with a higher development of breast cancer. And I think that that's going to be really important, because I know, again, back when we first started identifying risks and genes back in the late 90s when I was a fellow, you had to have a first-degree relative to even, be considered for genetic counseling. And I remember there was a woman, it's funny, no, even myself, my mother had breast cancer at 60, right? But, they were only considered high risk if they were 50 or less. She had 5 first cousins who had breast cancer, and one was 35 and had bilateral breast cancer, and was told over and over, you don't have a high risk. But people, when you step back and you look, and I know people have looked at their families and seen that there are incidences of cancer, breast cancer or other cancers that are unusually high, and there's probably some type of genetic change or mutation that's just not been identified. So this is a way with the wisdom study, you get a genetic panel that checks for some of the genetic mutations that we know put a woman at risk to some point. And I think that that's going to be really helpful in the future.
Right. I'm going to share a little bit of the data I was mentioning earlier about how the Wisdom study is doing in terms of representation. So just to go to that slide, I think you can see a new slide now. So what we've done since 2020, we had sort of a look at our enrollment data back in 2019 after a few years of enrolling in the Wisdom study and noting that we really weren't doing a great job of enrolling a more diverse cohort of women that represented the diversity of the country. And so we applied for and received an additional grant from the NCI to expand our recruitment centers, those hubs that Sarah was mentioning, to new recruitment centers across the country. And we chose intentionally certain hubs that had a much more diverse underlying population within their communities. So that included University of Chicago and University of Alabama at Birmingham, Louisiana State University, some centers in Florida, and then most recently we've added some communities in the border towns of Texas. We've also formed a community leadership board, and many of those members are on here today. They represent different community groups and or collaborations, both in California, where the Wisdom study started, as well as across the country, and really forming a think tank of how we can try and intentionally target and recruit women across the country who are from more diverse communities, build those community partnerships and those relationships, and build those trusted relationships through our community leadership board members. We started these community forums, again, as a way to have a dialogue and to engage with our community members and with our collaborators to see and to hear the questions that are out there. What's resonating, what's not resonating? Are there approaches that are being taken that are surprising, or what questions do you have? Because the questions you have are, I'm sure, questions that other people who are trying to consider joining the study would have. We've also worked with ambassadors. We've worked with the VA to launch a VA recruitment campaign as well. So really being intentional about trying to enroll a more diverse cohort of women over the last few years since the start of that funding from the NCI. And I'm happy to report, there's an article about it too, if you're interested in reading it in Stat News. It's, I would say, very honest, and it just really shows sort of the progress that we've made, but also the struggles that we had in trying to enroll a more diverse population as well. So we can send this link out too. It's a good read. But you can see since the start of the study through 2019, this is a little bit busy. So just to walk you through real quick, each of these columns is a different category of race and ethnicity. These are the typical categories that usually get reported in a research study. And then we have, prior to us starting our recruitment through the new grant, about 81% white non-Hispanic women participating in the study. And if you flash forward, we track every single quarter to track our progress. We've been slowly getting better and better of making sure that our population within the study is more representative. And so last quarter of 2022, we actually were down to about 60% white non-Hispanic. So we reduced that population by about 20%. And we increased our Black and African American population from 1.7% to 16.5%. So a huge improvement over time that you can see. If you look all time, it dilutes itself out a little bit from the early enrollment we had, but nevertheless, we've made great strides and really worked with our partners and worked with our community board to make sure that we can incrementally improve every single quarter each year. If you collapse those yearly categories, this is just a more succinct way to look at it. Similarly, 2022 was one of our best years in terms of the lowest percentage of white non-Hispanics and the highest percentage of Black or African Americans, Asians, Hispanic or Latinos, and those who report more than one race. And the importance of reaching out and having more hubs, you can see here, these are by site, just to highlight, our University of Chicago site contributes about 24% of Black and African Americans, University of Alabama about 28%. So a lot of progress being made, and a lot of hard work to make sure that we are focused on making sure that we have a more representative cohort within the study. There's a lot of great partners that we've made over the last couple of years, and I just wanted to share a couple of those resources. We'll send them out to you as well. Ricky Fairley, who is the founder of Touch, the Black Breast Cancer Alliance, has a weekly The Doctor Is In Facebook Live session. I know, Sarah, you were on it last week. It's a great conversation, hearing about different topics, particularly about breast cancer in the Black community. She's also started a movement called When We Trial to help to increase participation of Black women in clinical trials, and a couple of other resources here too. So just wanted to highlight those as some of our partners and collaborators that are really great resources if you don't know about them already. Yeah, let's see. So I just wanted to leave some time. I know we have about 10 minutes left to see if people had any questions. I don't see any additional questions in the chat, but please do feel free to add those in. We also have just some additional background information on Wisdom, but would love to hear what your questions are before we go into that. So please do add your questions to the chat. You can raise your hand or unmute yourself as well. You feel free to speak up if you'd like. And just while we're waiting for some questions to come in, Laura, if you have any other thoughts on this topic, otherwise I can show some slides about the Wisdom study, nuts and bolts.
Which in particular, just like when to screen or?
Yeah, oh, it looks like there is maybe hold for just a second. There is one question that came in. Kokoye, is that how you pronounce it?
Hi, my name's Coco Ye.
Kokoye.
It's not a question, it's a comment. I'm, have to think for a minute, 77, soon to be 78. And I was delighted to hear.
A parent's worst
that,
fear is to have.
Yeah, that you're going to try to get more women over that age, because, I mean, it happens. My cancer was late 60s, but I'd love to see the opportunity for older women to be able to be included in a trial, because the other thing I find is that I then tell friends and my daughter and her friends. And so I think we have the opportunity to kind of get the word out more if you include us. But if you don't, then we don't. So I was really glad to hear that. Thank you.
Well, I want to bring up that actually makes me think about a couple things that I think are really important. One is that, as you get older, it is true. Every woman, that cancer is in many ways a disease of aging, right? It's something that, things, when cells divide, it's a little, the cells are a little bit more fragile. And so it's easier for errors to arise, and that can spawn the abnormal development of growth of what turns into a cancer. Now, we assume that we have the ability to try and figure out who really has an extremely low risk of ever getting it. And even though breast cancer is very common, or 1 in 8 women get it, it's still 7 in 8 women never get it. And so one of the things that we're thinking about is, to try and make it risk-based forever. And it's possible that we will discover that we don't, know best or don't know how to do that. But, the data really does tell us that it's likely that we can stratify risk that way. So like if you have such a low risk that you probably should stop screening, you could stop screening at 70, 75 and be fine. Or if you have another really life-threatening condition, screening is sort of not the thing that matters most, right? So these are things that we could do. But for people who maintain and still have a higher risk, it may make sense for a much smaller group of people to really continue screening after 75. But it really gets to this point of, why are we screening? The whole point of screening is if you can find a tumor earlier than you would otherwise do it, and if by finding it earlier, your treatment would be better, safer, more effective. If in fact the treatment would be the exact same and the outcome would be the exact same if you found it 6 months or a year later, there would be no reason to screen because you're not really improving things. You're just finding it early and not maybe improving the outcome. And you're putting a lot of people through things they don't need. And I think it's one of these notions it's really hard to get across. And I think it's something that we need to figure out how to explain is that even if you're on a lower, a less frequent screening schedule, it doesn't mean that you would never get cancer. It means you're less likely to get cancer, and it's less likely to make a difference if we found it early. But I think what happens is whenever you find that cancer, the first thing people worry about is like, oh, I didn't go in for my mammogram, or I didn't do this is my fault, or I'm not, something happened because I didn't take an action. But a lot of times that action would be the same whether you were screened or not. And I think that's important to know that if you get diagnosed with the cancer, it isn't that it would have necessarily been better if you had screened 6 months ago and found it. And I think that's a hard concept to get across. And so I think it makes it hard to even think about changing the way we screen because of that. Does that make sense to people? That yes, it's true. Even when you're on a study like this, you can still get a cancer or a cancer can come up. But that doesn't mean that if you had found it 6 months earlier, that your outcome would have necessarily been better. In fact, a lot of the treatments are the same for certain kinds of cancer. It doesn't matter as much because we have, like for HER2 positive cancers, we really know how to give people the right treatments. So it doesn't matter often, and it would be the same if the tumor is 1.5 centimeters or 2.5 centimeters. So sometimes I think people assume, oh, if I'm screening less frequently and I get a cancer, I've therefore killed myself by not going in early, and that's not true. Because for a lot of these, it's really a matter of how well the treatment works for you. And if it works well, it doesn't really matter at all. Does that make sense to people?
It is a hard concept.
It's a hard concept. We should actually do a whole forum about this because it is really about how you explain to people, oh my gosh, I have cancer, but if I was screening every 2 years, how could you have told me to come in every 2 years? If I'd come in a year ago, everything would have been fine, which it might not have been. Chances are it wouldn't have been very different at all. But I think that's something that we do not do a good job of explaining and don't get that across.
And I think
Or is that true for the younger women and more aggressive cancers?
Well, what we found is it sort of doesn't really matter where you start. It matters where you end up. So if someone comes in with a 6 centimeter tumor, if I make it go away by the end of the 12 weeks of therapy or 24 weeks of therapy, it's as if they came in with a stage 1A cancer because we've shown that it's going to go away because we picked the right treatment. And so that's one of the reasons why we treat up front. But, that treatment probably would be the same if it was 1.5 centimeters or 4.5 centimeters. And a lot of those, and again, it's all about getting the treatment right. And so if you have a good response therapy, it doesn't matter when you came in. And a lot of times you can't necessarily screen those fast growing cancers and find them early because they grow fast. See, people like screening to be really simple and easy, but it's not.
Right. And I think one of our take home messages is always, even if you've had a regular mammogram and you feel a lump, don't wait. That it's a moment in time when that mammogram happened and those lumps can develop at any time. Those cancers can develop. So I think that's important as well. If you do feel something, even after a normal mammogram, always advocate for yourself and try and get that looked into. In case you hadn't seen, there's a poll that popped up that probably covered your window. It does have some topics that we have proposed for some of our upcoming forums. If there's something that is not in the options here that you'd like to add in, please add it in the chat and we can make sure it gets added to the list. As Laura just mentioned, I think this is a really great topic.
I don't know how to summarize it, but I've already put it on the list.
Yeah, it's on the list.
Someone asked, oh gosh, so someone asked, is there a better screening option than mammography? Not yet, unfortunately, not yet. And someone asked about digital or the 3D. 3D, everyone's just sort of adopted it as if it's better. It's not clear that it's that much better. It's more expensive, but it's not necessary. If they make you pay for it out of pocket, it's not valuable. If you have extremely dense breast, it may be helpful. One of the things that people are going to be thinking about, I wouldn't be surprised if IV contrast mammography for people with dense breasts winds up being a replacement for MRI. I think it's a very interesting, simpler way to do MR screening. So there's a big study that's about to start on that across the country.
I hope they ask women what they think of it in that study, patient-reported outcomes, because just the women I've talked to, the IV thing is a turnoff to them.
Well, okay, but it's replacing MRI, which requires IV.
I know.
It's not like it's not a zero-sum game.
Right.
Contrast, okay, if you are high risk and you have very dense breast tissue, you need a contrast exam. We don't have a substitute for it. I mean, you don't have to do high risk screening, but if you do, you got to do it. And it may be much easier, a 5-minute exam as opposed to a half an hour exam with MRI with less false positives. Right.
Okay, well, that's going to be a communication thing then.
Well, it is communication, just like the last topic I talked about, which, we got to talk about.
Yep.
So speaking of those all sound, I'm going to stop the poll and resume my share, but wanted to show the results of the poll. So it looks like most people are interested in hearing about breast density. I know there's a lot in the news about breast density these days, so we can definitely follow up and have another topic on that. Wisdom participant experiences, toxic and chemical exposure. So these are all great topics that we would love to share, and we'll get these organized, find some good speakers who can be discussants, and we'll add to the list the topic around screening and timing and benefits of screening. What is screening truly for, as Laura just mentioned.
So we could have Kim Rhodes and the whole group, that's looking in the Bayview, about the toxic chemical exposures and all the Superfund site cleanup stuff.
Yeah.
And then, and for wisdom participant experiences, that could be this jumping off point for trying to explain these complex issues around screening.
Exactly.
Hi, so sorry, this is Paris, and I'm actually unable to type in my question at the moment.
Sure.
I wonder if we can add the topic of high risk patients who have surveillance for high risk patients. Is that possible?
Yes.
Yeah, definitely.
Yeah, that would be great.
That's a great idea.
Yeah, and that can go into our discussion too about sort of how we come to our screening recommendations as well. I know we were wanting to get that explanation a little more clear for everyone too. So wonderful. Yeah, of course. Well, I know we are over time and I want to respect everyone's time, and big thank you to Dr. Sarah Horton for joining us this evening. Thank you so much for spending your evening with us, and Laura Esterman, thanks for joining as well. And to everyone who's on, really appreciate your participation, your engagement. We will send out a link to the recording if you're interested in sharing it or watching again. And you are welcome to email us, email me, contact the study if you have any questions, and feel free to share the study with others you may know. We are always looking to build out our community and would love to have more people join these community forums and these discussions. So thanks so much, everyone. I hope you have a wonderful evening.
Thanks, you guys.
Thank you.
Bye.